مساء الخير زملائنا الأعزاء. أرحب بكم في محاضرة Clinical Considerations in Dental Implant Practice. طبعا هو wide topic، وهحاول أنه من خلال هذه المحاضرة أنه نغطي بعض الجوانب اللي ما غطيناها في المحاضرات السابقة، وأتمنى أنه يكون الموضوع more engaging than the previous sessions, because the previous sessions were about biological, pathophysiological aspects in dental implant surgery. These are not really of clinical relevance toward most of the dental practitioners. I hope that this session will be more enjoyable. Before we go to the topic of the lecture, I just want to remind you a bit about the pathology of soft tissue healing. As you know, soft tissue healing is either by primary intention or secondary intention. The upper row represents the healing by the primary intention, and the second row represents the healing by secondary intention. By the end of the healing of a primary intention, as you can see from this diagram, the epithelium is thinner than the epithelium around the healing area. Of course, when we say healing by primary intention, that means that the margins of the wound are approximated and become in contact with each other, either by suture or other or adhesive or whatever tool that can approximate the margin of the wound, so they will become in contact, in direct contact. So what we will have here is that the thickness of the epithelium is less in the healing area, I mean at the site of the incision, and there is no rete ridges or rete peaks, which represent the invagination of the epithelium towards the underlying connective tissue. For the connective tissue, the area of the incision or area of healing will be predominated by collagen fibers. The vascularity will be less, the cellular elements also will be less, and also the elastic fibers will be less. So to conclude, at the area of healing, we'll have less thickness of epithelium and less resilient and vascular connective tissue. This problem will be more manifested in healing by secondary intention, because at the area of secondary intention, there will be a scar, and the scar, as you can see in the last slide, in the scar tissue, the epithelium, that the healing epithelium, occupies larger area, and they also for the connective tissue. I mean, connective tissue at the scar region. It's less vascular, less resilient, and there is less cellular element. That's why it's very important when we plan an incision, soft tissue incision, for the sake of doing surgery, we have to consider these factors. Now, what are the types of incision to be considered in dental implant surgery? First, there is the H incision, which extend from the first. There is an horizontal cut extend between the two teeth, and it's preferable to be more toward the palatal side, so the scar will not be visible at the labial side, especially in the aesthetic zone. And there is two vertical incisions that extend from the labial to the palatal. That's why it's called as an H incision. And you can see that the vertical incisions are in direct contact with the cervical area of the neighboring teeth or adjacent teeth, so that the interdental papilla will be included within the flap, within the surgical flap. This type of flap provides better exposure, of course, more visibility, better access, whereas the other type of flap, which is called mini flap, it is basically similar in design, but the difference here is that the interdental papillae are not involved by in the site of surgery, not involved within the flap. And this will have the advantage that we have spared the interdental papillae. Inclusion of interdental papillae means that this area, the blood supply of this area, will be jeopardized. Not only we will have a scar tissue in this area, and here the integrity of the soft tissue will be affected. Also, the blood supply will be affected, and the scar also will be more visible. So that's why there's a tendency toward minimal invasive flap surgery when we do dental implant. So in this case, we are here preserving the peri-implant soft tissue. The soft tissue that surrounds peri-implant, the dental implant, will be remain as much as possible, intact as much as possible. The only downside with this type of incision is that we have to make sure that the width of the flap will not be less than the width of the actual width of the implant itself. Of course, the flapless technique in terms of soft tissue healing is the best option. Here we don't have to use, we don't have multiple incisions. It's just one cut within the tissue. See, so the peri-implant tissue will be preserved. So here, the benefit of flapless surgery is we have better preservation of the soft tissue. The only problem with this approach is that we have to make sure that the dimensions of the bone are well measured and well calculated, because now we don't have direct access to the bone. So what we have to do is that we have to rely on clinical measurements by the use of bone gauge, also by the use of bone beam CT scan. In addition, we have to consider the irregularities in the surface of the alveolar bone. Because of the irregularities in the surface of the alveolar bone, some of the surgeons prefer to open a flap and level the occlusal, the crestal bone, make it in one level, so that they can make sure that the implant will be inserted and all the surrounding bone in with the same measurements. This type of incision or flap incision is called punch flap or punch incision. It's like punch biopsy, in which there is a soft tissue pair that cuts through the soft tissue, but not through the bone. And this will expose only the site of the bone in which the implant will be inserted. There is a very important advantage of IBS implant design, which is the magic thread design. The magic thread design, due to its depth and also due to the distance between adjacent threads, this will allow more bone formation in this region. So here I can, if I don't use, or if I don't open a flap, or in case I'm using a flapless surgery, it will be enough for me to have only 5 millimeters of bone, 5 millimeters of bone from buccal and lingual sides. Why? Because there is no reflection of soft tissue. The bone will be preserved, and I'm in addition, I'm sure that the bond between the two threads will be enough for the healing of the bone after the dental implant insertion. Now, this is the benefit of the design of the IBS thread. Whereas if I want to do a flap design, I have to keep the amount of bone not less than 1 millimeter, because there is a chance after the reflection of the flap, after the separation of the periosteum from the bone, because this separation will deprive the bone from its blood supply, so there will be a certain degree of bone resorption. So I need here to make sure that the remaining bone will be enough so that the healing process will not be affected and the bone will keep its integrity around the dental implant. There is an update with the dental implant design of IBS, which is the invention of Magic Core implant. Magic Core implant basically have two advantages. First, from the clinical point of view, it has two advantages. In fact, more than, but mainly two advantages. First advantage is that the gingival former and the dental implant become one unit. And there is a good variation in the level of the cuff, which is the soft or the smooth surface between the body of the implant and the part of the implant that will be exposed outside the gingiva, or exposed to the oral cavity. And because of this variation in the length of the cuff, I can utilize this variation in different areas where the bone level is not regular. The curvature of the bone, the crest of the bone is not to the level that make sure that I have equal coverage of implant surface on both areas, on all the dimensions. With the use of different cuffs, I can utilize these lengths, so can I will be able to deal with these differences in bone dimensions all over all through the four directions of the dental implant. So this is one benefit. The other benefit is that since the gingival former and the implant basically will become one unit, I will not need a second step surgery. And by this, I will get the benefit of, I will not do another incision. As I told you in the first slide, when I do another incision, that means I will do more trauma to the soft tissue. More trauma to the soft tissue, that means another area of damaged epithelium. The epithelium will become less able to withstand infection because it is thinner than the original epithelium. The connective tissue will not be as has the same will not have the same integrity of the original connective tissue. So here we will only have just one surgery, which is the surgery at the site of the time of implant insertion. There is another benefit, in fact, which is something related to the mechanical benefit. Because of the implant and the gingival former are one unit, the screw that will make sure to engage the abutment with the implant will be slightly longer, and at the same time will not extend into deep into the body of the dental implant. And this will give the inventor the chance to make the body implant is narrower, with having more chance of increasing the length of the thread. So by this way, I have minimized the size of the body, but I increased the depth of the thread. And with this, I'm having utilizing better the benefit of this type of thread design. There is another advantage, in fact, which is because there is no separation between the implant and the gingival former and subsequent abutment at the level of soft tissue, within the soft tissue, there will be no micro leakage or gaps or micro gaps between the body of the implant and the abutment in the future, which will further facilitate the growth of bacteria. Because the dental implant with its abutment now it's one unit. So this is an additional advantage of magic cord design, which is a new invention by IBS. Of course, it is out of the context of this session, but I find it useful to refer to so that when we do another course or when you start using this magic cord implant, there will be you'll have some preliminary knowledge. Surgical guide. Surgical guide is a useful tool for the dental implantologist to make sure that he is placing the implant in its proper position. Of course, you heard or you hear from time to time what the concept of surgically driven dental implant, prosthetically driven dental implant. The surgical guide work more the best, or it is more or less coincide with the prosthetic driven dental implant concept. You can use a manual method in which you can take an impression for the patient and use the surgical stent, and you can locate the exact position of the dental implant according to the occlusal relationship with the opposing teeth. And there is also the digital way, and the digital method in which you use the intraoral scan with the use of cone beam CT scan, and by sending the data to the manufacturer or to the company, the company will provide you with the surgical guide, digitally manufactured surgical guide, which will make it easier for you to insert the implant in the best possible way to achieve the concept of surgically driven dental implant. Of course, what you are seeing here is that the 4-in-1 dental implant concept, which is a concept that has been used by different dental implant company, in which I don't use 6 implants. I only use 4 implants for the full arch, which is something we can talk about later. Immediate implantation, I think you have practiced some of the cases, you have seen some, it has many advantages. First, I'm 4-month healing after that extraction. I'm saving the bone. The bone resorption will be less. If I have, in fact, I might have no dental bone loss because I have immediately replaced the missing tooth with the dental implant. However, I have to make sure when I do dental implant that I am not dealing with an area with active infection or pus is present. If I have an area with chronic infection, chronic granulation tissue, it's not a big deal. I can clean this area with thorough cleaning and debridement after the extraction of the tooth, and making sure that only bony socket is there. I'll be sure that I'll be kind of positive that the area is ready to be for the implant to be inserted. But if I have an abscess at the site, it's better to postpone the dental implant. The second important thing is that I have to make sure to minimize the trauma on the cortical plate, especially at the site where the insertion of the elevator or the forceps. The cortical plate is not really resilient and does not have the same ability as cancellous bone to withstand the pressure. So I have to protect it as much as possible. And this can be achieved by the use of, for example, power tone. The power tone was, its aim of the power tone is to separate the cortical plate near the neck of the tooth, so that when I apply the elevator or the forceps or whatever instrument I'm going to use to luxate the tooth or to remove the tooth, there will be less trauma on this cortical plate. Of course, I have to make sure that when I insert an implant at the site of extracted tooth, the level of the dental implant should be 2 millimeters below the alveolar crest, because after extraction, this area of bone will be resolved. So I have to consider this factor. So first, I have to extract the tooth, a traumatic extraction with the use of whatever possible method to protect the cortical plate near the site where the neck of the tooth will be grasped or engaged. I have to clean the socket thoroughly to make sure that only bony tissue is there, and then I can insert the implant, making sure that the area is clean and there is no trauma to the site of extraction. These are the periotomes. Periotomes are similar, are like the Copeland chisel. These are the tip of such instruments. They are similar to the elevators, especially the chisel, Copeland chisel. These instruments are used to kind of separate the cortical plate near the neck of the teeth, or the neck of the tooth to be extracted, so that they will be isolated further from the tooth and will be more protected at the time of extraction. After the research, after the cleaning, I can put the dental implant. This is a case of immediate implant in which I put the implant at the distal socket of the lower sixth. And because of the implant has been inserted at the distal socket, the medial socket has been left, sorry. Because of this, the area of the medial socket underwent resorption. You will be faced by this fact more often with the patients. The patients will come and tell you that the implant is larger than the other teeth or the adjacent teeth, or there is a depression in the bone underneath the implant. Some patients might find it difficult to accommodate themselves, and some of the food bolus might be stuck below the dental implant. This is very important to be considered by the dentist, and the patient should be informed that we are not replacing, when we are doing dental implant, we are replacing the tooth. If the patient is thinking to consider replacing even the bone geometry, bone or bone dimension, this means that we have to use bone augmentation material to make sure that the bone will be the same or similar or close to the original dimension as to the adjacent teeth. ليش تلاحظون هنا إنه neck of the abutment is slightly clear. I'm not really bothered by this, because with time, خصوصا the patient has a very good oral hygiene, the gingiva will grow. إنه الجنجبة tend to grow on smooth surface. مثل ما تلاحظون إنه الcolor of the gingiva after 3 months is very nice healing. The patient is well educated. الواقع هي أستاذة جامعية. So I am positively sure that the healing process will become better with time. Soft tissue closure. After I prepare the socket for dental implant and after I insert the dental implant, I have to replace the soft tissue for suturing. الانسجن اللي استخدم الطبيب هنا هو U-type incision. هو عبارة عن vertical incisions, two vertical incisions joined by a U-shaped incision on the palatal side. هذه أنا كنت أستخدمها كثيرا خصوصا لما ما كان عندي assistant، لأنه أقدر بهاي الحالة إنه أسوي reflection for this flap at the buccal side or labial side. وبالother hand I used to insert or drill the bone for the insertion of dental implant. هنا بعد ما أضع الدنتال implant هنا حرجع الفلاب slightly labial to its original position. هنا حيقلل التنشن على الفلاب لأنه حيكون عندي more tissue available on the labial or buccal aspect. فهذه advantage. هنا لو تلاحظون أن البيشنت أعتقد مستخدم النايلون سوتشر أو المونوفيلامنت سوتشر. بصراحة أنا جدا أفضل هذا التايب of suturing وأتمنى أنه تستخدمه. It's far more better than black silk suture لأنه black silk suture is braided يعني مضفور، وبالتالي خصوصا بعد مرور فترة خصوصا قريبة على منطقة الهيلينج حيكون a good chance for bacterial accumulation. And I find it more hygienic than black silk suture. لذلك أنا دا أميل بالفترة الأخيرة إنه استخدمه. يمكن تلاحظون إنه بعض أكثر المعلومات اللي موجودة بالسلايد كمادة مكتوبة هي مو هي اللي أحكيها، لأن هو مو الغرض إنه أعيد لكم المادة المكتوبة. المادة المكتوبة هي متاحة لكم للقراءة وإذا عندكم استفسار نناقشها، لكن المهم إنه أعطيكم بعض الكلينيكال تيبس متعلقة بموضوع السلايد وخصوصا فيما يتعلق بالصورة نفسها. أنا بصراحة إحنا ليش ليش أفضل الآي بي إس؟ الآي بي إس مو فقط إنه تعالج لي مشكلة الإكسبوجر أوف بون من خلال الفلابلس تكنيك أو المينيمال انفيزيف سيرجري. كذلك فيما يتعلق بالانسيرشن أوف بون أوجمنتيشن ماتيريال. لو تلاحظون هسه هو دا يحط بون أوجمنتيشن ماتيريال، فتح 3 سايد الفلاب وبعدين حط البون augmentation material، بعدين secured the collagen membrane by the use of screws، وبعدين سوى suturing. لاحظوا عدد السوتشرز اللي سواها. This is not an easy procedure for the patient. يعني for the sake of replacing the bone this is traumatic procedure. في حين إنه الآي بي إس أدى approach كلش يعني أنسب. الابروتش مال الاي بي اس انه انا اقدر بكل بساطه بعد ما اسوي penetration المنطقه اللي بيها bone deficiency اقدر انه اسوي reflection from inside، اقدر اسوي separation للميوكوبريوستوم from inside واضع البون augmentation material. هنا انا ما احتاج انه افتح فلاب، وبهذه الطريقه اقدر انه احط الامبلانت واني ابدا ما اسوي 2 sided ولا 3 sided فلاب. وهذه يسموها بالانترنال بوكيت تكنيك. اذا بالانتيريور ريجن انا ما احتاج بعد انه افتح فلاب حتى اسوي بون اوجمنتيشن. كل اللي احتاجه هو اني اساسا من مكان السوكت، وهذا نفس الكونسبت مال سي ام سي الساينس ليفت يوزنج كريستال ابروتش. انا ما احتاج انه انا افتح 3 سايد فلاب حتى اسوي بون اوجمنتيشن، من نفس المكان مال انسيرشن مال امبلانت اسوي بون اوجمنتيشن. فهذا ما يسمى بالانترنال بوكيت تكنيك. اكو another تكنيك تستخدم الاي بي اس وهو ايضا اشوفه جدا مناسب. هذه هو مكان الديبريشن بالبون. مكان الانسيرشن مال الامبلانت اسوي يو شيبت انسيشن واستخدم اسوي ريفلكشن internal reflection واضع البون اوجمنتيشن ماتيريال بمكان الدبريشن، ومن اضع البون اوجمنتيشن ماتيريال ممكن بعدين احط الامبلانت. وممكن انه هذا اليو شيب انسجن اسوي له سوتشرنج و اخلص من التو سايد، على اساس هنا من الحاله لا احتاجيت بون اكسبوجر، لا احتاجيت انه اقلق على السيبج اوف ماتيريال، الماتيريال حتكون محافظه على نفسها، بالتالي همات ما احتاجيت انه احط الكولاجين ممبرين، كل هذه انا استغنيت عنها. فهذا this is a useful technique. يمكن حضراتكم شفتوا انه انا احيانا استخدم التنلنت تكنيك، انه افتح الفيرتيكال انسجن هذه سايد واحط الامبلانت. هذا another technique ممكن انه تستخدم، لكنه يعني I prefer that you use the surgeon يستخدم التكنيك اللي موجود بالكتالوج او حسب الريكومنديشن مال الشركه، باعتبار انه هذه يعني something is published. التكنيك مالتي انا ما مسوي له اي publishing ولا يعني عندي عليه في الدراسه، بحيث انه اقدر ان اسوي لكم على recommendation because هذا this is my own practice. واحتمال انه انا بالفتره القادمه الجا اكثر الى ان استخدم هذا التكنيك، لان بصراحه هنا انا دا اقل السيرجيكال تروما. وانا دام انا دا استخدم نفس السوكت على مود البون اوجمنتيشن، فانا ما احتاج انه اسوي انسجن في مكان اخر، هو انا عندي نفس مكان السوكت اسوي به الاوجمنتيشن، وبالتالي ممكن احصل الفائده المرجوه من السيرجري. فلاحظون حضراتكم انه كل هدفنا بالشغل مالتنا هو reduction of trauma للسوفت تيشو وتروما للبوني تيشو. اكو مساله كلش مهمه فيما يتعلق بالتروما للبوني تيشو، هي مساله انه شو وقت يصير عندي اوفر تروما، وبالتالي احتمال يصير عندي بون ريزوربشن. فيرست اذا كان عندي اوفر هيت لازم اكون واثق تماما انه انا عندي good irrigation technique good cooling system. اذا ما عندي بالهاند بيس فد نوزل بحيث انه يكون ينطيني continuous stream of normal saline، ممكن استخدم سرنجة disposable syringe with continuous cooling البير على مود اضمن انه ما يصير اي دمج للاوستيوسايت، درجة الحرارة ما تزيد عن 37 درجة مئوية. المسألة الثانية هي مسألة insertion of implant ممكن يكون traumatic إذا احنا استخدمنا، خصوصا فيما يتعلق بالاي بي اس، إذا استخدمنا الاوفر تورك. عادة الشركات تقول لك انه استخدم حتى ل 45 50 تورك ماكو مشكلة. بالاي بي اس لما انت تستخدم البي اي بي تكنيك يفضل انه ما يكون التورك عندك عالي. السبب لان انت اللي تسوي بي اي بي تكنيك انت قاعد تحاول انه تسوي كومبريشن للبون. الكانسلس بون ما بيه مشكله، المشكله عندك بالكورتيكال. الكورتيكال بون ما بيه ذيك المرونه، فحاول قدر الامكان انه لا تستخدم التورك العالي، لانه بالتورك العالي معناها حيصير عندك بريشر عالي على الكورتيكال بون وراسا حينتهي عندك بون ريزوربشن. فلذلك من تستخدم البي اي دي تكنيك تجنب التورك العالي. اذا تدخل الامبلانت وشفت انه انت تحتاج حتى توصل الامبلانت المكان مالته الى تورك عالي، توقف، شيل الامبلانت، ارجع وسع بالبي اي بي تكنيك، زيد قدره البندنج مال الكورتيكال بليد وقبل ما تضع الدنتال امبلانت. هاي المشكله انا ما عندي بالبي بي ار تكنيك او السنجل دريل تكنيك. ليش؟ لان اوريدي الدريل هو اعرض من البادي، الدريل اعرض من البادي، لذلك ما عندي مشكله بالتورك، لان already there is no direct contact ما بين البادي of the implant والسراوندينج cortical plate. الكونتاكت يصير ما بين الامبلانت ثريد والسراوندينج. هذا اللي احب انه اتحدث به فيما يتعلق بهذا السيشن. اتمنى ان تكون المحاضره مفيده لحضراتكم، وان شاء الله نتواصل مع بعض فيما يتعلق بالاسئله والاجوبه. والشكر.